Yep.
Hello. Thank you for joining this webinar. I hope you get value out of the presentation that I'm sharing with you today. I'm Allyn Peters. I'm the Clinical Supply Program Director for Banner Health. My background is in the NICU. I've been a nurse for 30 years and worked most of my bedside career in the NICU. So moving on, I'd like to tell you a little bit about what I expect to share with you today. First, a little bit of the history behind the initiative to reduce the risks of small bore misconnections in clinical care. Also talk about some strategies of identifying and engaging the stakeholders to support the Right Route initiative. And then finally, to list the components of an effective implementation plan for the products involved. Going on, this is my organization that I work for. Banner is a large IDN in the western United States. We have 28 acute care hospitals, 3 academic centers, and more than 400 locations throughout the western United States. You can see from this slide that we're a pretty big organization. So this was not an easy initiative to complete, but we managed to get there, and I'll share some of our experiences with this. Going back to a little bit of history for the standardization of connectors, back in 1988, there was a mid-air collision of some air show airplanes, and what they discovered with that collision, the planes crashed to the ground. There were injuries both in the planes as well as the observers. And since this was a U.S. Air Force base and based in Germany, they had different lure lock connects or different IV connects. So the first responders ran into a lot of challenges around how to take care of these patients. You'll see here on the slide, the American lure lock device was used by the Army first responders, and the German first responders were using a record connector. This created a lot of turmoil during the response to this collision, and it became very obvious that there needed to be an international adoption of one style or one design of IV connection. Ultimately, the decision was made to go to the lure lock design. Going on with the history, early in the 90s, the needleless connectors came into existence. They were used to reduce the risk of needle stick injuries, but what they found once they started bringing in the needleless connectors was that lure or slip tip syringes could also could access those ports. So we had a new problem that we had to address. How do we avoid attaching a feeding to an IV with these needleless connectors? So early on, and this goes back in my history, early in the 2000s, the manufacturers started coming up with their own ideas of how to prevent the access of lure needleless connectors with a slip tip syringe. So they had many different ideas. One was to add on a device. So they either glued or they heat seated or they put on some type of locking tip on lure lock syringes or slip tip syringes and felt that this might be an option. Some manufacturers increased the diameter of the slip tip syringe, and others had proprietary designs. None of these were acceptable alternatives, and without a uniform design, it was near impossible for anyone to be able to adopt a safe mechanism for feeding supplies. So for Banner, we went and we started considering what were our options, and GEDSA was formed, and I know that everyone that's looking at this is aware of GEDSA and the history that they have with enteral supplies and loaded or small bore connections. So when Banner started looking at this, we decided, okay, what is it that we want to look at? What are the questions behind adopting ENFit? So what we found out is there is no consensus on color. Some manufacturers use purple, some orange. There's even some blue and some green out there in the market. So color was not going to be a deciding factor for the adoption of ENFit. Proprietary design for anyone that works in supply chain or is at the bedside when they find out that something is not available, that can really cause turmoil in taking care of your patients. So a proprietary design would really limit our ability to provide care to our patients when we don't have, if one of those pieces or components is not available. So the next thing was, as the ENFit design came into existence, there was the discovery that the tip of the ENFit syringe really impacts the accuracy of the low doses. So your smaller, less than 1 ml dosing, and they had to go back to the drawing table and come up with the low dose tip, which has now been approved by the FDA and is on the market. And then the other question is there a mandate or is there regulation? At this point, there is not, but there's a lot of work going on behind doing that. And then some manufacturers are holding out. They're not convinced that the design is going to be the final design, so they're waiting before they put a lot of investment into producing product. For me and for Banner, the reason we decided to move forward with this is that there are products out there that can reduce the risk to our patients. So why would we continue doing something that has been shown time and again to add risk to our patient care? So for us, now that we have products in the market, we decided that we needed to move forward with implementing ENFit products. So some areas to consider as you're going through an implementation or preparing for an implementation there are many different off-label uses, both for feeding supplies that are used for other purposes and other products being used for feeding purposes. So you have to really look at where are products being used. The big areas for consideration are peri-op and imaging. They use a lot of feeding tubes for urinary catheters in infants, and we need to be able to prepare and find an alternative for them once ENFit is implemented. Other items or other things to consider are departments that may be doing their own direct orders for other products that you may not be aware of when you're starting this whole process. You need to look at your custom packs. For Banner, we do our own custom packs, so we have a little bit more investment in the process. For those of you that are purchasing custom packs from a distributor or a manufacturer, you will want to make sure that your custom packs are compatible with what you're using in your facility. Pharmacy is another area to really look at and have these frank, open discussions regarding how they are going to implement. Slip-tip syringes are not going to be going away, at least not for now. So pharmacy does still have the ability to use slip-tip syringes. But at the bedside, those tips will not fit to an enteral feeding tube. So there needs to be some adjustment if pharmacy is going to continue to use slip-tip. And then the next thing to think about for pharmacy is what kind of light protection. A lot of the ENFit syringes at this point do not come in an amber design, although I hear more manufacturers are starting to produce them. So the implementation process, this was a long-term process that we had to engage in. What we did was we started with going to the leadership, providing them with the information that they needed so that they knew that we're doing this in the best interest of our patients, and to get them engaged, help us to identify the project leads, within the facilities, within the different disciplines. Engaging with all of your providers really makes a big difference. And then we needed to determine what our current state was. So what products do we have in use today? How are they being used? Who is the person that's going to be able to answer the questions, the difficult questions when you say, okay, we're going to commit to this, but where are the barriers? What do you foresee as barriers as we move forward? The next item, the meeting with suppliers, was really an eye-opener for me. I did meet with suppliers very early, about 6 months prior to our anticipated go-live date, but I feel like you really have to have that monthly meeting with them, make sure that they know everything that comes up along the way, include them in any internal discussions regarding what you're looking at for go live. So who's going to be providing the support, who's going to determine the education that needs to be done, and how will the suppliers support the process. And then do your cross-reference early. I don't encourage anyone to change manufacturers in the middle of this, because that just adds another level of complication to the already complicated process. So confirm your cross-reference early and then go back and confirm several times before you make your initial orders. So preparing for ISO 80369-3, or as we know it, Enteral Connect or ENFit Connect, you start early and you start with recruitment. As I mentioned, I talked to the leadership, the facility leadership, and had them help me get the right people on board. Some of the disciplines that I have on this list I learned later, so I had to scramble to get people engaged later on. But these are just the groups that I worked with, and I think we've pretty much gotten a hold of everyone that we need to. So supply chain is crucial. They know what their inventory is. They know what their ordering practices are. They can help you with working through depletion of product. You want nurses involved, because if you give a nurse a syringe that doesn't look familiar, he or she is going to panic. So you don't want to have those panic situations, especially at the bedside, where it could impact a patient. Dietitians were crucial to this process. I was surprised at how involved they are in the process, but they were a huge support and really helped me to identify some areas that I was not prepared for, such as the discharge coordination. Pharmacy I've already addressed. The EMR, your informatics team needs to be on board. They need to be able to, when the patients are receiving feedings, they need to be able to document what it is the patient is receiving and what route they're receiving it. I would encourage you to start the EMR discussions early in the process, because as we all know, IT can get backed up and it can sometimes take months to get things done. The discharge coordinators, as I mentioned before, was an eye-opener for me, because ultimately when they plan for discharge, they're communicating with any home care settings, any long-term care settings, home equipment companies. So they need to be able to communicate to those outpatient contacts as to what they need for these patients. So they were a big help for me. They also helped me with the informatics part of this. The clinical educators are crucial. They're going to help you with the communication to the staff that's going to be using the supplies. I asked them to work very closely with our suppliers to develop the education and to put it out to everyone. I didn't put it out too early. I prefer to do it in a timely fashion, because if you give them too much information too early, it sometimes becomes overwhelming, and it creates some panic that isn't necessary. For Banner, we do have our own home care agency. We also have our own home equipment agency. So I worked very closely with them. In doing that, I could only recommend what Banner was doing during the hospital stays. But for the other referral agencies that your patients may work with, your patient's insurance may work with, I encouraged all of our suppliers to get in touch with all of the local agencies to make sure that they were aware that this was coming. And then you want to work with your ancillary departments so that they can help you understand any products that they're using today that they may not have realized may be impacted by this. As I mentioned before, the feeding tubes being used as urinary catheters in infants. So this is just the summary list of groups that I worked with. And as I said, I've added names and groups as we work through the process. So I hope you find that part helpful as you start working forward with your implementation planning. So for implementation strategy, like I said, you really do need to notify your suppliers and your distributors of what is coming. Give them a little bit of an idea of what your timeline is. I encourage you to set a timeline and stick to it as best you can. I realize that sometimes things happen that may delay it a little bit, but you don't want to see delay after delay. So for our situation, we planned on going live in February of 2018, and as we worked through with our suppliers and our distributors, it became apparent that we were going to have to delay a month. So instead of February, we went live in March. So we did stick to that. Once we decided to delay it that month, we stuck to that timeline. So you want to work with your supply chain, as I said, to deplete your inventory and place your stocking orders early. Your supply chain team will know what their PAR levels are and how much they bring in to stock all of their PAR locations. So they should be able to predict their inventory or their stocking orders that they will need to place, and I encourage them to place those orders early so that they know if there's any holdbacks or any back orders on anything, they can start working through what they were going to do to alleviate any shortages. So that work with the suppliers and distributors and supply chain really was an integrated process. And then for education, as I said, I had the clinical educators work closely with our suppliers to develop our clinical education. Lessons learned through this process, there's never a perfect time to change. We all know that change is difficult, but ultimately my perspective and Banner's support of this perspective is if there is a risk to a patient, we do need to make sure that we alleviate that risk. And a small bore misconnection is definitely a high risk for patients, and we don't want to see anyone harmed while we wait to make a decision. Another piece that I knew about but didn't really work too much with until later in the process is verify your community adoption status. So the other healthcare organizations, the other providers within your community may have a different timeline than you have. It's important that everyone in the community is aware that this is something that's coming along and what your timeline expectations are for your organization so that they are at least aware and they can prepare for any challenges of maybe a patient coming from your organization to another organization and making sure that they have the supplies that they need. I think I've said this enough, but make sure you partner with your suppliers and then determine your implementation timeline. We started about 6 months in advance, and there are days when I feel like we probably could have started 8 months in advance. Remember that we are a large IDN in multiple states, so there were a lot of pieces and parts that we had to address that an individual freestanding hospital won't have as many of those complicating factors, but it's still important to make sure that you get people on board and engaged early. And as I said, stick to your timeline. And then plan a contingency plan. So what if a patient comes into your facility and has an ENFit feeding tube and you don't have supplies in your facility yet? What are you going to do? What if the patient comes in with a legacy device and you have done your full implementation of ENFit? Those are things that you have to start thinking about. G-tubes, implanted feeding tubes, can sometimes be in for years before they're replaced. No provider is going to willingly change an implanted tube just because they don't like the connection that's on them. So you will see both ENFit and legacy feeding tubes for a fairly long time. With that being said, no matter how long you wait to implement, you will still have challenges with patients that are going to show up in your facility with a legacy tube for months and maybe even years down the line. So as you go through the process and you start bringing in the products, you will have to keep some type of supply, whether it be a cart or a special shelf somewhere in your warehouse where you keep legacy supplies for those what-if scenarios. You need to come up with some idea and some plan for that. I think that's all I've got for lessons learned. There is industry support. ECRI has published a guidance article for reference. Of course, we know about GEDSA. The ISMP, Safe Medication Practices, has an alert out regarding the safe delivery of medications with the ENFit design. ASPEN also has supporting documents. While Joint Commission has not necessarily made a recommendation at this point, I know from our facilities we have had some surveys over the last year or so, and we have had Joint Commission surveyors ask the question, what are you doing to prevent small bore misconnections? They won't ding you for it, but they do ask the question now, and I think it's really getting the word out that this is coming. We can't hide from it. It is going to happen, so it's best if we start to prepare early. So the question is, if not now, when do we do it? Do we wait for a mandate? Do we wait for all products to be available? Wait for the discontinuation of legacy products? Or wait for someone else to go first? What about your patients that are admitted from other organizations that show up in your facility with an ENFit tube? Or do you wait for that mishap to occur and then have to address that after the fact? So these are just some thoughts that I had as I went through and I started to present this to our leadership at Banner. These are the questions that I brought forward to them. And not surprisingly, I was very happy to have leadership say, there's no reason to hold back. Let's do it, let's get it done, and make sure that we make our patients safe. So in conclusion, it's been a long time coming, starting in 1988 with the lure lock connection issues, in the early 2000s with the drive to get away from needle sticks and prevent needle sticks from happening, to manufacturers trying to come up with their own design of an enteral-only device, to today where we have many vendors, most vendors, who have embraced the ENFit design and are actually producing products now and able to take on the new business. So the manufacturers are out there, they're ready. Not everyone has gotten on board yet, but for the most part, you can get everything you need today to provide safe connections for your patients. Remember that conversion requires changes in practice and products, and changes are always painful. I don't care how well you prepare. You do have challenges along the way. You want to make sure that your key stakeholders are included early and that they help to develop the plan for the conversion. Engage your suppliers. It's important to get partners within the continuum of care space involved. As I mentioned, you don't want patients discharged with ENFit tubes and the suppliers don't have the products that they need to care for the patients. After careful planning, the conversion can happen and make your patients safer in your organizations. And that's it. I have my email address at the bottom of the slide. Don't hesitate to reach out if you have questions.